Okay, we're going to talk about COVID-19 management. طبعا this is the trend now. COVID-19, it's the obsession of the world. Okay. عندي أجندة للكوفيد-19 اللي هي عبارة أول شيء راح نتكلم الانترودكشن معناته what is the COVID-19 من أي سلالة يجي transmission اللي هو طريقة الانفكشن how to prevent it and the symptom the treatment and if the treatment non-invasive way then invasive after intubation and eventually will be weaning and extubation post-extubation assessment وراح ناخذ simple case study. Okay. معلومات عن الكوفيد-19 كلمة CO stands for coronavirus. طبعا الكورونا فيروس يرجع لسلالة قديمة من فيروسات زي الميرس-كوف. سابقا 2014 كان عندنا ميرس-كوف وقبلها كان عندنا الكورونا الإسبانية يسمونها فمو توا شيء جديد. VI from virus word and then D from disease of course. So في النهاية جمعت صارت كورونا فيروس أو كوفيد. هنا هذه تفكيك كلمة كوفيد. أوكي. زي ما قلت لكم بالعربي هنا a new virus has been linked to the same family of viruses يرجع لإيش السارس which is يعني eventually أصلا هو common cold. فإن شاء الله زي ما طلع عندنا vaccine للcommon cold يطلع عندنا vaccine للكوفيد-19. Okay, how does it spread? معناتها the infection. Most of the studies they said it's a droplet that means بالرذاذ عبر العطاس أو الكحة السوائل من الفم أو اللعاب. أوكي. في ناس يسألون هل ينتقل بالدم؟ لا ما ينتقل بالدم ينتقل بس بالريسبيراتوري droplets secretion. حلو؟ هذا الانفكشن generated. عشان كذا they always advise you to wear surgical mask and once you wear it do not touch your face and the other surfaces. This is how the infection transmitted. So once you wear your mask, sometimes you're touching your nose under the mask or you're touching your mask and touching the other surface, it's already infected. So you're infecting the furniture or someone else when you shake hands. Okay, there are certain people, they have higher risk to get infected, say age, elderly, اللي هو plus 60 years old, they have higher risks to be having severe symptoms, cardiovascular diseases, respiratory conditions زي heavy smokers اللي عندهم مثلا COPD هذول يكونون عندهم عرضة أكثر والديابيتس اللي هو الDM. وكثير فعلا أنا شفت عينة من هذول الناس dying easily like butterflies going up. How to prevent طبعا يقولون لك خير العلاج أحسن من العلاج اللي الوقاية. How to prevent? It's simple things by staying home if you feel sick or having symptoms or even suspect يعني لسه ما جاتك symptom لكن زي أنا أشتغل in a medical field and I suspected myself إني عندي ممكن the virus فأعزل نفسي and staying at home حتى بين الأهل and wear mask even at home. Covering the mouth and nose as you can see from here and you have to pinch here so you can seal it and don't forget once you cough or sneeze try to dispose your mask, wash your hand and wear a new one. Okay, of course the key of all infection control is washing hand with soap and water. It's better than alcohol. Don't forget also to clean the surfaces whenever you touch. في عندنا نوعين من السيمتومز اللي هو mild اللي أغلب الناس تجيها والسيفير اللي هذه تحتاج medical care. أوكي المايلد زي fever اللي تحت 39 you can only take paracetamol or فيفادول أي مخفض حرارة you will be fine إن شاء الله. Cough زي ما قلنا you have to cover your mouth and isolate yourself from others. هذه the most common which is loss of taste and smelling. الأغلب كثير يقولون لهم لأن يكون عندهم تضخم أو التهاب في الغدة بحيث إنها تضغط على الأعصاب وما يكون في إحساس. حلو. السفير شلون تبدأ؟ shortness of breath، يبدأ ضيقة نفس، بعدين شوي شوي يكون عنده hypoxemia، وإحنا صرنا نسميها happy hypoxemia. that means عنده drop of O2 in the blood and he's not feeling it. يعني كثير patient أشوفهم يتكلمون يضحكون عادي يسولفون معاي والساتوريشن حقهم 70. I was shocked at the beginning. فصرنا نسميها happy hypoxemia. اوكي، وراح نتكلم شلون نعطيهم the proper care of the hypoxemia. نمونيا لما يتطور ويصير طبعا نمونيا راح أوضحها لكم هنا في الجست إكس راي، بتشوفون شلون الانفلتريشن. آخر شيء لما يصير ARDS which is acute respiratory disease، لما يصير intubated ويدخل في عالم الكوفيد 19. أوكي، زي ما قلنا لحد الحين ما في confirmed vaccine. So أحسن شيء البريفنشن، treat the symptoms زي ما قلنا، مثلا الحرارة، إذا كان عنده هايبوكسيميا نعالج الهايبوكسيميا. كثير دراسات الحين وضحت إن البرون position is the best for treating the hypoxemia. self proning إذا كان البيشنت conscious، و typical proning اللي إحنا نسويه إذا كان البيشنت unconscious or sedated. أوكي، إذا ما نفع معانا any simple low flow or high flow O2 device، ننتقل للنون invasive. عندي 3 أنواع: CPAP، BiPAP، والحين صارت هبة جديدة أو ترند الجديد high flow nasal cannula and the helmet. Eventually going to invasive if failed. طيب، زي ما تكلمنا low flow مثل يكون عندنا النيزل كان العادية، إذا كان عنده small desaturation like saturation only 90 or 88. طبعا إحنا بالنسبة لنا acceptable saturation 88 or 92 and above. فإذا كان عنده small desaturation just give him. إذا كان البيشنت عنده shortness of breath انتقل للهاي flow اللي هو زي النار breather mask أو high flow nasal cannula. إذا ما نفع معاه هذا لسه عنده shortness of breath with desaturation، ننتقل للCPAP and BiPAP and helmet. طبعا هذه highly infectious، فلازم إذا راح تشبك على هذه الأجهزة يكون في negative room pressure. That's my advice. Even the high flow nasal cannula لأنها عبارة عن رذاذ. أوكي. الهاي فلو نيزل كانيولا عبارة عن FI2 and flow with a humidifier زي ما انتم شايفين هنا corrugated tubings and the high flow the nasal cannula. اوكي، هذه هي. طبعا تسوي ست للFI2. في بعضها أجهزة تعطي 100%، في بعضها تعطي only 95. أنا جربت كذا جهاز كذا براند زي الفيشر، جربت كمان الانسبايرد، وجربت أشبكها على الدريجر ماشين. My favorite is the Draeger. طبعا لازم نسوي ست للتمبرتشر، نضبطها تقريبا حوالي 36 35 to 37. هذه التمبرتشر اللي عادة نحطها فيه. And fill it with irrigation water, not normal saline. That's what I want to advise you. Many people they fill it with normal saline. ليش ما نحط له normal saline؟ لأنه عبارة عن أملاح، في النهاية بيكون فيها رواسب وما تنفعنا وراح تسوي obstruction أصلاً. وليش تعطي يعني البيشنت أملاح؟ ف don't forget irrigation water. أوكي. طيب، في ناس يقولون لي على أساس أنا أسوي السيتنج. الFI2 طبعا يتحكم في الأكسجينيشن، الفلو ممكن يساعدني في CO2 wash up. طبعا الانيشال سيتنج أنا أعطي 100 FI2%، أبدأ gradually decrease it على حسب saturation and the VO2 from the ABG. الفلو احنا نحطه from lower to the higher. ليش؟ لأن الفلو بيكون مرة قوي مرة عالي و irritated، فلا تعطي البيشنت strong. أعطيه في البداية 15، ما نفع معاه شوف الwork of breathing. ها أبوي أنت مرتاح؟ Are you feeling well? If he's not, go up by 5 gradually. Our maximum is 60. okay. طيب، الحين ننتقل ل the new trend اللي هو الهلمت. زي ما انتم شايفين هنا عندي هذه الهلمت، في طبعا several brands. عندك 2 parts. واحدة تحط فيها الانسبيراتوري واحدة expiratory تشبكهم في الفنتليتر. And especially in the expiratory you have to put bacterial viral filter اللي هو الهيبا فلتر طبعا عشان to minimize الانفكشن. في بعضهم يسألون ليش عندي فتحات هنا. ممكن بعضهم حتى تكون الفتحة هنا ليه in case of the patient want to drink some water or some of them want to eat. طبعا when you want to feed or give water try to minimize the pressure لأنه بيكون عنده high risk of aspiration. حلو. I have a lot of questions received about the nebulization. You can connect the nebulization but most of it will be lost in here in the helmet لأن انتوا زي ما انتوا شايفين it's not direct to the patient's mouth or nose. So you can hook it to the inspiratory but remove the filter. Okay. But I don't think it's going to be effective. يعني جربناها كم من مرة في السيفير cases اللي ما نقدر نشيل فيها الهلمت قلت لهم نشبك النب هنا يعني في small beneficial 10 to 15% only. أوكي إيش السيتنج اللي أنا أحتاجها في الهلمت؟ طبعا أول شيء لازم أسوي لها تيستينج قبل لا أشبكها على البيشنت. شلون؟ أوكي في هنا عندي ربر قبل لا أحطها على البيشنت أسوي obstruction للربر هذا بحيث إنك تمسكه seal it well with your hand and start your setting on pressure support of 6 and beep of 10 total of 16. في النهاية بيكون سيباب أوكي سيباب بيكون total pressure of 16 we start it and see it will inflate it. إيش الحكمة إن أنا أسوي لها testing عشان إذا فيها أي malfunction أو يعني leakage you don't know about it will appear. It will be fully inflated and you will see is it fully inflated or no. If it's not fully inflated that means it's ruptured. You have to replace it. Of course I forgot to mention it comes in sizes. Okay, we have small, medium and large and I think we have also extra large but I only use the medium and the large. That's the most common. And once you test it, stop the machine again, hook it to your patient, check the neck size. Some of them, they say it's too tight, so you have to get it out again and try to cut in a horizontal line like this. Do not cut like that because you will ruin it. So cut like this. The more you cut, the more dilated it will be, but do not leave it too loose لأن بيكون عندكم طبعا leaking. فخلوها شوي tight and put for the patient some towel around the neck or deoderm which is similar to the skin plaster عشان يخفف irritation ويكون patient more comfortable on it. اوكي يلا الحين ننتقل للسيتنج. عبارة عن زي ما قلنا طبعا نشبكها في الفنتليتر نختار non invasive mode. لازم تحوله من invasive إلى non invasive. بعدين نختار CPAP pressure support. السيتنج راح يكون عندي pressure support of 6 and beep of 10. The total CPAP will be 16. هذا initially الدراسات اللي الحين بدينا احنا عليها ونطبقها. ال FI2 احنا نحطها 100 and then as I said go down as per saturation and PO2. إيش اللي يساعدني في الفنتيليشن والCO2 removal اللي هو الفلو. شلون أتحكم في الفلو عبر لها calculation عبارة عن التايدال فوليوم على الانسبيراتوري تايم. الانسبيراتوري تايم راح نحطه 1. حلو. فلما تحسبها راح يطلع لك كم الفلو اللي المفروض يكون عندك. The more wash up the more you will increase. How to increase the tidal volume طبعا عبر ال pressure support with the PEEP لأنه راح it will reflect for you on the minute ventilation. minute ventilation راح يبين لك في شاشة الفنتليتر by 20s يعني don't be shocked إنك بتشوفها high number. حتى التايدال فوليوم راح يصير عندك 1000 إلى 2000. don't be shocked. ليش؟ لأنها open space. It's not inside the lung. It's not invasive. Okay, so don't be shocked by the huge numbers you will see. To help up also with the slope, نحط السلوب تقريبا 0.5 yeah 0.5 sorry 0.05 it helps also to wash the CO2. تمام. ننتقل للي بعده. الحين البيشنت عندنا مثلا cannot tolerate the non-invasive, so the doctor will decide to intubate. How to do intubation? As you can see, this is also a new trend. We do it now. Some of them they put plastic bag, يعني على حسب ميزانية المكان وقدراته. لكن this is يسمونه البوكس. As you can see, they insert the hand to minimize the infection لأنه high risk. Opening the mouth and using the some of them they use the CMAC or the kaleidoscope. Hello. So we'll talk how to do the intubation. First of all, protocol says should be only 5 healthcare professionals inside the room, not more than that. As you can see, at least 1 anesthesia, 1 RT, nurses at least 2, and 1 physician. Hello. And connect HEPA filter, as you can see in the picture here, with the ambu mask, between the ambu bag and the ambu mask to minimize risk of infection also. Do not forget the CO2 detector, because once you apply the intubation or the oral ET tube inside, you will remove the ambu mask and ambu bag with the entitled CO2 with the HEPA filter to check is it correct intubation or no, because you cannot auscultate the patient. You'll be wearing a full gear of BBE. Okay, and have clamp. Why clamp? Also to keep it close system. So once you intubate, you will clamp the tube, then hook him to the ventilator and clamp it. Easy peasy, okay? Piece of cake. Okay. COVID-19 عبارة عن wet lung, يعني infiltration of the lung. That means secretion or fluid in the lung. So eventually it will lead to ARDS. فصاروا يعاملونها معاملة ARDS protocol. إيش ARDS protocol? Accept of acidosis until 7.25. Some of them say even 7.20. حلو؟ فبيكون عندي high CO2 شيء expected, and the PO2 will be at least more than 50 or 55, and do not forget the PF ratio at least more than 200. إذا كان less than 200, they will prone the patient, prone position to the patient. Saturation acceptable 88. طبعا tidal volume you will set it as per 6 kg or 5 to 4 even. High RR, that means more than 20. And don't forget the eye time will be less than 1 second عشان نسوي compensation between the eye ratio, and give high beep to do recruitment. السيتنج بشكل عام هذا هي. عادة نعطي recruitment set the beep more than 5 to give good recruitment, لأن ال ARDS ما ينفع معاهم ال high of I2, ينفع معاهم البيب recruitment lung expansion. أوكي وضحتها already. أوكي weaning and extubation، يعني بعد ما يكون البيشنت intubated ويعطونه antibiotics. sorry antibiotics أصلا ما راح تنفع معاه لأنه viral, it's not bacterial. خلي نقول يعني لما البيشنت يكون fine يبدأ يصحصح، يعني الجي سي اس يكون عندي more than 8 والsedation will be weaned off وما عندي inotropic support زي النور اد أو الدبيوتامين، وما عاد عنده حرارة يعني normal temperature. وإذا كانت عندي الفنتليتر setting less if I2 less than 50 and beep less than 8 with normalish ABG, it does not has to be perfect but at least in the normal side, and the minute ventilation does not exceed 10, Also, make sure when you do the weaning the RSPI before extubation less than 105. لأن لو كان more than 105 معناتها he's having shallow breathing, which is eventually will lead for failure of extubation. Our new protocol says do not check the cuff leak. Why? لأنه once you deflate the cuff, it will leak and you will have the droplets اللي هو الرذاذ فراح تنشر الانفكشن زيادة. Okay, this is the procedure of extubation. This is from British study guidelines. This is how they do it from A. First, they put the ample mask, and you can see here they have clamp. So they will put the ample mask with HEPA filter, deflate the cuff. The position actually should be high Fowler, not this position. Then remove the tube under the ample mask because he will cough, so all the cough should be protected in here, so less risk of infection, and you can help him with some recruitment maneuver, or there are even special devices that give cough exercises to help up the patient to cough the secretion out. Okay, post-extubation, of course, you will give him a type of autotherapy. Usually we give aerosolized to reduce the inflammation after the intubation because the ET tube causes some irritation in the throat. So cold mist is advised. The positioning, we recommend high Fowler. Sometimes we give IS if the patient is fully conscious and obeying command. CBT, which is the machine vibration. Repeat the ABG, of course, after extubation to make sure the patient is not retaining CO2 or failing. Okay, now we will have the case study. But before I start the case study, do you have any question regardless what I have explained already? يعني نرجع لأي no questions عشان ناخذ الكيس study وإذا ممكن تبون بعد الكيس study again any question. Okay, so the case study هذه أخذتها من المستشفى. Typical case study. We had a patient 33 years old, male, medically free, complaining of continuous fever. طبعا الحرارة كانت عنده تقريبا 39. He tried to treat it, but it's not going down. He had runny nose. Suddenly, he was found at home unconscious. They admitted him to ER. They intubated him immediately. بيسألوني ليش intubated ليش ما جربوا معاه and non-invasive. Of course, because he is unconscious. Okay, that's why. This is the reason. So we intubated him to secure his airway. Then we added these settings, which is BRVC, pressure regulated volume control. FI2 100% because we just intubated him. We had no idea about the blood yet. So we did the ABG after intubation, which is post. This is the pH 7.26, which represents uncompensated respiratory acidosis with severe hypoxemia. BF ratio, as you can see, 56. So we proned him على طول, and we did him recruitment maneuver. We did him chest X-ray post intubation. As you can see, the bilateral infiltrates. As you see, it's very obvious. This is typical COVID-19 X-ray. We ran a sample for COVID-19. It came positive. So we adjusted the settings depending on the previous blood gas. So what did we do? We did lung recruitment. How? We increased the PEEP 30 for 30 seconds, and then we kept it at 10 after the 30 seconds is done. The tidal volume by 6 kg, not 7. The RR increased. as you can, sorry, it should be from 24 to 30. Should be 30. This is my mistake. I did not correct it. And the inspiratory time decreased to help wash up of CO2 and less obstruction or accumulation of the CO2 to compensate the IA ratio. Okay, I tried to copy the ventilator screen from what I had before. The pressure, as you can see, that's why we are saying it's ARDS patient, because we have high pressure, poor compliance with higher resistance. So then we repeated the ABG, it's got improving, but the patient's still intubated. So I will try to update you with the improvement of the patient, inshallah. These are my references. I took it from our Saudi guidelines and British guidelines and World Health Organization. And we are done. So what's your question? Any medication given to COVID patients? Okay, medications, they started actually trials of plasma. So the people who had COVID-19 and they are recovered, they have antibodies of double G. They take their blood and they treated them with these antibodies. هذه اللي من جد نفعت معاهم. Respiratory wise احنا بس buying them time. لما نشبك على ventilator ولا helmet, it's not a treatment لأنه ما هو medication. لحد الحين زي ما قلنا it's viral فما تنفع معاه antibiotics. لسه في trials على medication viral بس هذه من تخصصات الدكاترة ما راح أتفلسف فيها. أفضل مود أوكي لأن إحنا قلنا it's ARDS فأفضل شيء تستخدم معه pressure mode لكن في عندنا الحين شيء اسمه BRVC which is pressure regulated volume guaranteed اللي هو تتحكم في البريشر with set tidal volume فهذا أفضل شيء نستخدمه. البيشنت اللي ما يتحسنون ممكن we switch them على APRV but be careful with the APRV. If you are expert, I recommend APRV. If you are not expert with the ventilator or this mode, don't put it on. لأن ال APRV يسوي لك continuous recruitment وأفضل شيء لل ARDS lung recruitment. Any other questions? Okay. Do you agree with taking vitamins to protect ourselves from COVID-19? Vitamin C, as we all know, it's يعطينا better immunity. So good food, supplement of vitamin C. طبعا لا تاخذ vitamin C from yourself. No, you have to check لأن في تسمم من الفيتامينات. فتest yourself and consult your doctor about the dose. Yes. And exercise. Exercise actually recruits your lungs. What's precaution the stuff with COVID-19? Okay, what are we wearing? We are wearing N95. طبعا لازم تسوي لنفسك N95 fit test. We protect the N95 with surgical mask لأن زي ما تعرفون الحين الستوك is low. So what we are doing, it's يعني انتوا عارفين إنه ال N95 mask single use and drop it. But for the crisis, what happened? We wore N95 above its surgical mask. ليش surgical mask? To protect the N95. فلما I dispose the surgical mask وأغيره. وكمان الفيشل شيلد ليش؟ to protect the eyes from any droplets. لأن لما مثلا تشبك على high flow نزل كانيولا بيكون عندك رذاذ في كل الغرفة وممكن يجي لعيونك ينتقل عبر السوائل هذه. And also the hazmat suit. But if you don't have the hazmat suit, it's okay. You can wear yellow gown or even surgical gown for aerosolized procedure. إيش معنى aerosolized procedure؟ زي الintubation لأن surgical gown أو الهازمت suit it's water resistance. If you have tracheostomy, any invasive aerosolized procedure, we recommend the hazmat suit. If you don't have the hazmat suit, the surgical procedure, surgical gown will do it. Okay, next question. Many people talk about vitamin D and its role. To be honest, I have no idea لأنه اللي نعرف إحنا الفيتامين C boost your immunity. فيتامين دي يعني اللي أعرفه يتعلق بالعظام الأورثو، فما راح أتفلسف في شيء ما لي خبرة فيه. ممكن أتفلسف في الريسبيراتوري وايز، ميديكيشن ما ميديكيشن يعني الأغلب يقول لك إنه eat well يعني eat good food, healthy food, exercise well and don't smoke. هل مريض الكورونا موضوع في قسم خاص في المستشفى؟ It should be in a negative room pressure. Yes. يعني some hospitals like the hospital I'm on, we have a special building even for corona patients. وحتى الستاف نقسمهم كوفيد 19 وكلير، على أساس اللي يتعامل مع الكوفيد 19 ما يروح مع المرضى الكلين وinfect them. That's what we do. Any other questions?